Thank you, Dr. Musa. It's my pleasure to be here today with you. Thank you for the invitation. Today, I'm going to talk how can we treat no reflow in a really practical way. So this is well said from an ancient Chinese warrior who said that you need to know your enemy very well before your battle, that you will have a real big chance to win your battles. So knowing your enemy is really important. And this is really true regarding no reflow. We need to know what are we dealing with. As no reflow, it's considered myocardial tissue hypoperfusion despite a patent epicardial coronaries. And understanding the pathophysiology of this phenomena is really important to know how to manage or how to prevent the bad outcomes. As we know, the prolonged occlusion and restoration of the flow is a really can cause structural damage to microvascular circulations. So, and really, of course, affecting the scars healing. So let's meet our first patients today. This is a male patient, 38 years old. He has risk factors of dyslipidemia and hypertension. Presented with inferior STEMI, transferred directly to the cath lab for primary PCI. Left system is good. Then this is the RCA. As you can see, there is an obvious big thrombus in the mid part of the vessel, even extending to the proximal segment. So immediately we managed to cross the occlusion. We used a hydrophilic wire. It was really tricky to pass this branch here, the marginal branch. But anyway, we managed to cross the occlusion. Then immediately, as my standard to use directly in such a huge thrombus, aspiration, we used it. I used it many times just to try to get rid of this big thrombus. Then after thrombus aspiration, I had this little improvement in the flow, but as you can appreciate, it's still TEMI1 flow. So after that, my routine just to try to get the microcirculations or the no reflow out of the equation. That's why I went distally, as you can see here, with the microcatheter past the occlusion here, and I selectively injected through or directly inside the BLV and the BDA here in the right side. And you can see flow is really good in the microcirculation. Flow is really good with a rapid disappearance of the contrast. So after that, I knew that all the problem is due to the thrombus blocking the proximal and mid part of the artery. That's why I continued more aspiration and more thrombectomy extraction. And this is what I had in the final results. I didn't use stents. I only used the thrombectomy with drug-coated balloons. Then patient discharged on dual antiplatelets for a plan of OPD follow-up, and he was asymptomatic. Let's now move to our second patient of today, and we'll compare between this patient and our first one. This is another male patient, 49-year-old, history of PCI, previously PCI to LED and distal RCA. He also presented with inferior STEMI and shifted, of course, for primary PCI. And this is what we had in his RCA. As you can see here, there is a big thrombus in the previously deployed stent in the distal part of the vessel. So as our standard of care in my center, directly we use thrombus aspiration at the site of the thrombus just to get whatever we can from this big thrombus. That's And this is the angio after first aspiration. There is no much improvement. Actually, there is, as you can see, this is the to and fro flow. Maybe no reflow is the here the cause. Maybe other like diffusely spasm or the dissection, thrombus, whatever. So again, I went distally with the microcatheter, and you can see here how is the flow here is impaired and compared to my first patients. This is the flow here in the microcirculation is really compromised, and microcirculation. So now I diagnosed I had no reflow phenomena here in the microcirculation. That's why I kept, and I brought these two images just to, if you can compare between the flow in the first case and in the second case, you can, of course, appreciate how is the difference between two cases. So in this case, I just kept the catheter or the microcatheter distally in its place. Then I manually injected vasodilator drugs and antiplatelets, adenosine, sodium nitroprusside, 2p3A inhibitors directly, selectively inside the distal part of the vessel. That's followed by more thrombectomy of the clot inside the distal part of the vessel. Then this is what I had after injecting a vasodilator inside the microcirculations and more thrombectomy. So that's followed by RCS stenting at the site of the occlusion, and I did imaging. Because I really try as much as I can in the no reflow phenomena and acute vessel closure to avoid post dilatation as much as I can. So I did IVUS just to check the stent deployment, expansion, whatsoever. Unfortunately, I didn't do post dilatation here, and this is what I ended by in this patient. One more thing just to add, and after this patient, I kept the patient in CCU, IV 2B3 inhibitor was given for 24 hours, then patient discharged as usual on our antiplatelets for follow-up. And one more thing just to remind myself and you with, no reflow is not usually a benign phenomena. This is a different patient that he developed after he developed a neuroflow. He had hypotension, bradycardia, that necessitating to put him on temporary pacemaker, impella. So a neuroflow is a really can lead to disasters and more complications. So this is my way how I can deal with no reflow. If I had a no reflow, especially with acute patients, just I start with the thrombus aspiration. I try as much as I can to avoid pre-dilatation, not to make things worse by distal embolization and whatsoever. Then if the flow is not so good, put microcatheter distally, try to see what's going on in your distal coronary circulations. If you have a good flow, then it's all about mechanical problem. Just try to deal with it. If flow is impaired, like our second patient, so you have or you had a no reflow phenomena, try to deal with it. Give intracoronary selective drugs in your microcatheter. Giving too much drugs in your guiding, it won't help anymore, because it's by definition, it won't reach the distal circulation, and it may increase the side effects systemically of the vasodilator and whatsoever. So giving drugs inside the microcatheter is really a good thing to do dealing with your no reflow. So this is my summary and conclusion today. No reflow is a common, it's not uncommon. Plan should include differentiation between different causes of acute vessel closure. If you are dealing with no reflow, so microcatheter is a must and should be used for intracoronary drug administration and multiple pre-dilatations, stents over inflations, aggressive post-dilatation should be avoided. Thank you very much for your attention.
Thank you,